Hello, welcome back. I hope your week has been all right. I feel like we are just going through a lot of life storms at the moment, not in our lives, but in the lives of close friends and family. These things come in waves. So I hope that your life is less tempestuous than ours. So we're back here in the windy outcrop, the very beautiful windy outcrop that is the East Neuk of Fife, to bring you a conversation with Joanna Myers, who is a physiotherapist. She's going to be talking about the very complex world of pain, and she's a specialist in pain management. Joanna started off working with sport injuries and then moved into chronic pain care. She has so much knowledge about our kind of evolving understanding of pain, the critical role of resilience, and why we need more holistic approaches to manage it, sort of on a society level, really. We discuss a lot about movement and how it can be a really important part of the pain journey in managing that pain, especially for those facing chronic pain. So let's jump in and I'll be back at the end.
How to stand on shifting sand. How to bend but stay intact.
Okay, today I have Joanna Myers, and Joanna Myers, she works as a physiotherapist, and I might mangle this, but you're also a specialist in pain, and you work at a pain clinic. Okay, good. And Joanna reached out to me actually a few months ago now. I put out a blog post about hurting my back and just talking about my own experience with back pain. And Joanna, who you remember at Wild Strong in Falkland.
That's
Is that
correct,
right?
yeah. Yeah.
And you very graciously reached out to me, and we had a really nice conversation. And as soon as we started talking, I just thought, I'd really like to get you on the podcast because I think that you have a great perspective, lots of experience thinking about pain and talking about pain and helping to treat people who have pain. So you very generously said that you would come on and do the podcast. So thank you very much for your time.
My pleasure.
And I guess I'd just like for you to introduce yourself if you could. So really, who are you and what do you currently do now? And then we can talk from there.
Okay, great. Well, it's nice to be here. So my name's Joanna. I'm a physiotherapist. I work in a pain service in the NHS and as one of the lead physios for the service. I've been in that role since about 2016.
Mm-hmm.
And prior to that, I worked at a pain clinic in Canada, which was quite a different setting for a variety of reasons. And prior to that, I worked as a physiotherapist in a sports injuries clinic, which is generally far more acute injuries and a different side of things. But there's lots of similarities as well. So that's what I do. As a physiotherapist in a pain clinic, we're what's called a non-interventionalist service, which means we don't do injections and things like that. And really what we do in our service is help people to understand their symptoms, why they have chronic pain, and the neurophysiology behind that, and to help them manage their pain so they have a better quality of life despite having pain.
That's great. I've taken a few notes. There's a few points I want to pick up on, but I guess while I'm still talking about your history, so you started off doing sports injuries, and then over the course of your career, you found yourself working in pain clinics. Was that a conscious decision? as your career matured, or how exactly did you find yourself becoming more of a pain specialist and moving away from the sports injury side of things?
That's a great question, actually. So my initial degree was exercise and sports science. And then from there, I went and did a post-degree qualification to become a physiotherapist. And all I really wanted to do was sports injuries.
Yeah.
So I worked in musculoskeletal services and then emigrated to Canada and was lucky enough to get a job in a sports injuries clinic in a ski town. So it was fairly much a revolving door of, well, there were some work-related injuries, but it was acute injuries and lots of torn ACLs and MCLs and lots of acute sports injuries from ski accidents or mountain biking accidents, that kind of thing. And it was great. I really loved it. It was a great clientele. It was really interesting. But for a variety of reasons, including financial, I also took another part-time job in a local pain clinic. And over time, the revolving door of sports injuries with short appointments, there were 15 minutes for follow-up appointments, just became less appealing. And I realized that there's so much more going on, even with an acute injury, than just the physical aspect, and that we're all far more complicated. We're not just a body part.
Yeah.
And the more holistic approach, and I was working in the pain clinic, I was working in an interdisciplinary team. That approach with psychologists and occupational therapists and kinesiologists was a bit more interesting after a while for me, and was working with people as a whole person, and also longer appointment times where you got to actually get to know them properly and look at all aspects of their issues. So that's why I kind of then transitioned from the sports side to the pain side.
Well, that's great, because that actually that flows into my next question, because when you were first talking about your experience, you talked about this idea of neurophysiology, and then you've also, you said that people are much more complicated, and, obviously pain is a complex problem, sort of sits in different layers as we make sense of it. And you were talking, about the need to think holistically. And I guess I was going to get to that later in the conversation, but I think actually that this is a great place or a great time to get into it, which is a two-part question. So tricky one.
Okay.
Okay. How has the language and conception of how we talk about, think about, and treat pain changed since you first started? Okay. And then within that, okay, and you can take as much time as you want. What is it? I think there's probably a lay conception of pain, which isn't necessarily incorrect, but, pain is your body sending a signal that says there's something mechanically wrong with me. I cut my finger, it hurts. It's a direct, A to B relationship. And I think based on what you're saying, it is probably more complex. So if you could talk about how the thinking has evolved, and sort of, if you were going to try to speak to a patient and have them make sense of their pain, how would you start that conversation?
Okay. So the first one, so the first question about the kind of what is understood by pain. Yeah, the definition of pain has actually changed in 2020 with the International Association for the Study of Pain, and it's recognizing more both the sensory but also the emotional experience, and it's also taken into account now. It's changed to be more that it's recognizing that it may be actual or potential tissue damage. And the central change in the new definition, and I'm reading this out actually so that it's not just me telling you, the central change in the new definition compared to the old version is replacing terminology that relied upon a person's ability to describe the experience to qualify as pain. So it has changed to be a more person-centered definition as well. And that really is in line with kind of what I've seen in practice as well, that generally there's a better understanding of the more holistic, all-encompassing impacts of pain. So pain is not just a physical sensation, it's also an emotional experience. I don't know, does that answer that question?
Yeah, it does. I think
Yeah.
that's a really starting off point, and I think that gives us a good foundation to sort of talk about the different aspects of that. So that's great. Thank you.
Yeah. And tell me the next question again.
Well, I guess it was a two-parter. It was, yeah, how has our conception of pain evolved with time, especially since you've been in practice?
So it has,
and I think that covers that. And then I guess if you actually here, I'll give you perhaps a better question, a better way in. The population of people that you work with, I think, has changed quite a lot. You know, without presuming too much, I would think that when you were working with a lot of ski injuries and mountain bikes, I would assume that was probably mostly middle class population, generally probably quite healthy, you know, people who have these acute injuries, but generally would otherwise describe themselves as healthy. And I think working in pain clinics now, you probably, well, actually, I don't want to put words in your mouth. How is the population different now in your current role than when you were first working in more of the acute sport injury side of things?
That's a really interesting question. And as you were talking about it, I was thinking, well, actually, I don't know that they're that different. Some of them were, yes. Some of the acute injuries were people who were doing well, life was fairly stable, but there were quite a few people who were coping and living well, but it was a fairly finite balance between that and a tipping point into not doing well.
Yeah.
So obviously in sports injuries, for the most part, you don't delve in, especially with short appointment times, you don't delve into childhood histories and histories with what else is going on in life. I mean, you do get a bit of that, but there was certainly a sense with some of the people I worked in sports injuries. A lot of them, because it was a ski town, a lot of them were working 2 or 3 jobs. They were working really hard. They weren't earning lots of money, but they loved to ski or they loved to mountain bike, and that was their passion. But it was also often a coping mechanism for other things. We all have those.
Yeah.
And so sometimes there was a tipping point, and if they couldn't get back to that activity that was their coping mechanism, things started to maybe fall apart.
Yes. Okay.
So then, but you're right. The people I see, for the most part, it is varied. Anyone can have chronic pain. Doesn't matter about your socioeconomic status, your education. We all get chronic pain. Actually, it's pretty darn common. But the distress that we tend to see, the people with the really disabling pain that I tend to work with, they have often, but not always, had things happen in their lives that have caused them to not necessarily feel that safe, and they're trying to function almost on shifting sands and unstable ground.
Yeah,
that's a metaphor, not a reality, obviously. But so their systems may already be in fight, flight, or freeze for a variety of reasons, and then that can, and so then pain can come as a result of that, or it might come as a result of an injury or an illness, and then that can make the distress far more significant, and recovery harder.
I see.
Did that answer your question?
Yeah, it did, and I think it's led into the next question, which obviously, without divulging any personal details, and I know that you wouldn't, but I think just to have something more tangible so someone can grasp onto, could you sort of give an example of not even a specific case study, but what it might look like if someone were referred to you in the pain clinic? What are some common examples or some commonalities that you might see? So someone comes in for perhaps one specific or acute reason, and then your role of trying to disentangle their perceptions of pain and where it sits and looking at it holistically. If you could just kind of walk us through what that might look like for some common issues that you have seen.
So we see a lot of people I see have a diagnosis, or not always a diagnosis, of fibromyalgia, which is widespread persistent pain, along with significant fatigue. But we also get people who have chronic back pain. Maybe they've had surgery, maybe they've not had surgery, and a variety of other things. And it might be post-injury, and it might just have come on gradually. For chronic pain, you'll have to have had pain continuously for at least 3 months. And patients are only referred to our service if they have medical closure, and if they feel hopefully ready to work with a multidisciplinary rehabilitation approach. So generally, there's a variety of things that are quite common with patients that I work with. So they may not have felt heard or seen by healthcare professionals and have felt disregarded. That's not always, as often, not the fault of anyone. It's just their perception and the reality of the life they're experiencing. Distress is a massive component, and a fear of getting worse, and shame is often a common pattern, a common factor. And daily activities such as getting dressed or making food or having a shower feel like a massive mountain to climb that is not always achievable.
Yes.
And probably that you had that when you had your back injury. But you had the background and stability, I guess, to work through that and for things to improve. Whereas the patients that we work with in a chronic pain setting don't always have that stability and don't have the knowledge behind them to progress, and it's the distress that is the biggest thing. And I myself have had I mean, it's not particularly back injury, but I have a back niggle that's on and off, and sometimes I've had a back spasm that's been acutely painful. And even me, knowing what I know as a physio and working in chronic pain, I have to tell myself, this is just the muscle spasm. It's almost like it's an innate protective instinct that we go into fight, flight, or freeze with pain.
Yes.
And if you're already in fight, flight, or freeze for other reasons, then that can just really become a significant issue and can drive this pain experience that becomes more and more disabling and distressing.
No, you're right. And I was lucky in that when I hurt my back, and I would say I was in that hypersensitive sort of fight or flight, where any kind of disturbance to my back would just cause me to absolutely seize up. I would say I was probably about 2.5, 3 weeks, maybe just shy of a month there. It was probably about a month before I felt like I had the confidence and the ability to go out and walk without the fear of taking a wrong step and just having my whole body collapse. And what you were saying there is true. That's amazing, because I've already forgotten some of this. But the feeling, the embarrassment of not being able to put your own socks or underwear on or getting in and out of the shower is one thing. And the feeling of being a burden, especially, having a wife and 2 young children. And that was really just a 2 or 3 week period. And the idea of dealing with some variation of that at a chronic long-term level, I could see how absolutely disempowering it is. And you're right. I think all sorts of pain can trigger this fight or flight response. And I don't know if it's because it's cultural or if there's some physiological base, probably some combination of the two, where there is something about that acute extreme back pain that really just causes people to freeze up, with like, I think, a really deep fear, because so much of it, and I think you can speak about this more eloquently than I could, it's not even just the pain, it's the fear of the pain coming back and how that
Yeah.
constrains the way you move, where you sort of feel like you have a very narrow band of movement you have access to, and any aberration from that, you are just so afraid that you will get that spasm again, you'll get that pain again, and it just hems you in, so much. So I guess with that, there's a lot of ways we can go, but I guess I'd like to go back to when you reached out to me after my blog article, and I wasn't even going to write it. Jill, my wife, she asked me just to write something, so I put it down, and I was surprised that it got such a big response, because it was just me sort of talking about my experience, but quite a few people reached out to us, just talking about similar experiences and things like that. You were one of the professionals who reached out. Was there anything in the article specifically that made you want to reach out to me, or anything that you thought, either things that you agreed with or disagreed with, or things that you just wanted to discuss specifically about some of the things that I wrote about?
I think, well, one, I felt bad for you that you'd had a bad experience with a physiotherapist.
Yeah.
I'm glad you also then had a good experience. You mentioned, I haven't read the article in the last few days, but Peter O'Sullivan,
Yes.
and so the pain science side of things, and I thought that was really interesting and valuable for everybody who was going to read it, because it is really important to be thinking of those of this information about pain, because society's understanding of pain is quite limited and based on very acute pain and the medical model. So
yes.
I think it was that, and I had been, because I started attending the Wild Strong sessions in Falkland in the summer of 2024. Having been, it felt very unwell for me in the spring, but I mean, it was just a long sinus infection, but I felt acutely unwell and very sorry for myself. And I'm sure I had completely irrational feelings at some points during that illness, but I felt quite vulnerable after that. And so then having always been very active and outdoorsy, starting Wild Strong and feeling more confident, and that it was helping me build up my resilience. I think a combination of your article and the importance of building resilience, which people with who are very distressed by chronic pain generally have a lack of, not through their own fault, but due to life circumstances, often that way anyway. That's what made me want to reach out to you, because really, I really think that people living with persistent pain would benefit so much from being able to build up their resilience and their confidence in themselves and their bodies through something like Wild Strong, although absolutely not to the level that most of us are working at. But and I think that was what made me reach out, because the people I work with have no confidence in themselves, no confidence in their bodies. Pain wears you down. So even if you were resilient before, it wears you down and can really shake that resilience and sense of self. And I think that was it. That was why. So it's a combination of factors is the short answer.
It's good, and I've got 2 points I'll take from there. But the confidence is so important. Not even just dealing with pain, but just the sort of stories that people tell each other, and their sense of efficacy, their sense of capability. And I think that's one thing we do more than anything else at Wild Strong, is really try to give people the opportunity to build their confidence. And so much of, especially when we're working with newer members, is a self-talk. I can't do that. I'm not capable of that. Things like that. And often it's very rarely about physical capacity. It's just about getting your own self-story aligned with what you can do. Because we see it all the time. And, in some ways it's gendered. And I think that'd be probably worth talking about as well, is maybe the way that certain aspects of medicine perhaps haven't served women in dealing with chronic pain. But in this case, there's something about seeing women who are physically strong, and you know that they're strong because they carry their children around on one hip and they pick them up and put them into bed, and they can carry these, bags filled with all, their children's milk bottles and everything like that. And then you get them in a situation, it's supposed to be like a fitness situation or some kind of physical activity, and you just see that they lack the confidence to interact with the world around them.
Yeah.
So I think that is really important. But what
Yeah.
I would like to talk about is, because you mentioned Peter O'Sullivan, and he was someone, and his ideas and his conversations that he's had have been very helpful for me. So I was wondering if you could talk about Peter O'Sullivan, some of his work, but also situate him in perhaps the other models that he's in conversation with. So maybe what are some of the dominant models or the contrasting models, and then who is Peter O'Sullivan and what does he espouse?
Right. I'm not sure I can actually fully answer that. That seems well, I'll give it a go.
Yeah.
So Peter O'Sullivan is a physiotherapist from Australia who is quite leading in, and the Australians have been really quite leading. If you think of Lorimer Moseley and David Butler in chronic pain education and information sharing, Peter O'Sullivan has developed, which I've not done the training for, I keep wanting to do it and it's never happened, cognitive functional therapy, which is essentially what we do in our services is, and particularly with regards to backs, and this is what we talked about before, is I don't know what it is about backs, but people feel that their backs are very vulnerable and fragile, and actually backs are really strong, and they're not fragile. They're designed to move, and they're designed to lift things and be in awkward positions. So that's a lot of the work he's done. And I did listen to a really interesting interview with Dr. Chatterjee. Is that how you said it? And that was great. It was about what is a pain clinician. But the one thing that struck me, and this is not to do him, I feel like I'm not doing him a disservice. I don't think I'm doing him a disservice. I don't agree with it. I don't disagree with anything he said. But the examples they were using were chronic back pain in someone who's generally fit and well and has some knowledge about pain and health. Whereas a lot of the people I work with are not in that character, and the distresses, I'm not saying they weren't distressed, but it was quite different. So Peter Sullivan has got some great work about kind of the impact of language, and in fact he's used the coaching wheel as well, the different aspects of life how satisfied, where are you at with each of these aspects of your life in his work. But I wouldn't say I'm an expert at his work, but he's a leading voice in chronic pain, as are a lot of the Australians.
What are some of the counter voices or counter models? Because when I first came across his work and other people he, I guess his colleagues, I found it really revelatory and quite empowering, because, going back to this idea of permission, it really made me feel like, oh, you know what, I can work within this sense of pain. And if I keep, if I keep the right attitude, if I'm able to prevent myself from sort of wallowing in the wallowing is fair for me. I wouldn't use it for other people, but I think, sort of like you were saying when you were dealing with the chronic, with the sickness earlier last year, like I do have a tendency sometimes where if I'm a bit ill, I can catastrophize. I don't think I'm worse than other people, but it's one of those.
I think we all do. I think it's natural.
Yeah. But I think that, I'm quite lucky because generally I am healthy and I have a good support network, have around to help me. So, I'm able to snap out of it. But back to O'Sullivan. So I found, when I found this line of thinking, I found it very empowering. And I think in some ways it's in contrast to some of the other narratives that have been out there, some of perhaps the predominant narratives within pain. And I was wondering if you could kind of help situate sort of what he and his colleagues are saying versus perhaps stories or myths or beliefs that sort of permeated their way through society.
Yeah, it's really good to hear that what he was saying was empowering, and we do hear that from people. I do hear that from people I work with, and I guess the biggest thing it's not against, but the biggest kind of the main narrative that has been going on for a long time is the medical model. So pain equals harm.
Yeah.
And so even though there is a greater understanding of pain, particularly chronic pain now, in some areas, and certainly within the field of chronic pain, it doesn't seem to have, and I mean, a lot of clinicians are really well versed in chronic pain, but it doesn't seem to have found its way into all areas of the health care profession. So society and unfortunately, a lot of healthcare professionals' understanding of pain is based on the acute pain model, and acute pain is very different and more simple, really, than chronic pain. So it's based on, you have an injury, there are these structural changes that happen, and then gradually you heal and get better. And if you've still got pain, then there's something that needs to be found and treated.
Yes.
And we do still hear that a lot from people that we see. And so that's kind of the main part of the medical model. The other part of the medical model is that I need to have medication, or we need to give you medication to make this pain go away. And in chronic pain, because chronic pain is so complex, medication will not take away the pain. And so that's the other aspect. And so it is looking at the far more holistic approach, looking at all the factors that feed into the pain experience, as well as all the factors that are affected by the pain experience. And that is what makes the difference. And that is what all Peter O'Sullivan and all the Lorimer Moseley and David Butler and certainly our service work within that model, I guess.
Yeah, it's interesting. It hadn't really occurred to me, but I'm thinking as an American now, and I'm thinking of the ongoing opioid crisis in America.
Yeah.
And how researchers have sort of mapped the prevalence, especially the first wave of the opioid crisis in the 2000s. You can map it almost directly over deindustrialized Rust Belt areas, where people probably were already dealing with disruptions, lack of stability in their lives, and things like that. They were experiencing chronic pain, but it probably also meant that because people were applying the medical model of just giving people painkillers for the experience of pain, you see how that can create the sort of autocatalytic cycle of people who have issues in their lives being prescribed, possibly overprescribed opiates, and you see how that could snowball out.
Absolutely.
You've talked about resilience quite a lot, and I'd like to bring it back to your current work in the pain clinic, where if somebody comes in and if you're sort of looking at this holistic model, and what you would ultimately like to do is to perhaps give them tools or narratives or somehow help them build up their resiliency and hopefully help with the chronic pain there. What does that process look like? How do you start helping people get out of this, this hole?
Good question. So we generally start by asking them lots of questions. Asking them about their lives, because and we often hear, not always, that they don't feel they've ever had the chance to tell their story. And telling your story is in itself very powerful. So being able to tell your story and to feel properly seen and heard can make a big difference. That's the starting point. And obviously we need to do an objective assessment and do that aspect of things and see kind of where they've come from, where they are now, what do they want to achieve, what are their goals. And most of the time it's not, run a marathon or anything like that. It's maybe be able to just get out of the house once a week, or do things with my kids, that kind of thing. It's fairly basic stuff that a lot of us take for granted. And that's where we start. And then probably one of the key things that can help people build their resilience and move forward with pain is understanding pain. So we give information about persistent pain and why it persists, and then have a think with that person as to why they think their pain may be persisting. And sometimes there's no real reason that anyone can identify, but that's where you're at, and pain activates that fight, flight, or freeze part of your nervous system, and it can just get into a bit of a vicious cycle. And particularly if you've got if you tendency to anxiety, then those two things feed off each other. Pain can make you anxious, as we all know, so it becomes that vicious cycle, and you do less, and then your nervous system doesn't tolerate as much, and it becomes that vicious cycle of pain, and you get more deconditioned, and you have more pain, and you have less confidence, and maybe you're on more medication. So we really, the main thing we do to start with is listen and figure out what their values are, what they want to work on, and then education is really important, but it's not, right, I've told you that, now you know it. It's a matter of repetition, because we know that people take in a maximum of 10 minutes of information in an appointment. Our appointments are quite long, so we're not expecting them to take it all in. We give them things to have a look at as well on their own. And that information will probably need to be repeated. And then looking at factors that they think will be helpful for them. So it might be things like having a toolbox, a metaphorical toolbox or a real toolbox full of things that they know help with their pain, or they can try, such as heat and relaxation, or watching a funny film, or, distraction, things that help build up their tolerance and that helps to build up the resilience and helps in a flare-up. And then we look at the things that are important to them and what they might want to work on, and we take it from there. It really is led by the patient. We do strive to have patient-centered care. Now, sometimes because we're the clinician, they want to be led by us to some degree, and certainly it's that knowledge sharing is really important. But we're all the people that know our own bodies the best.
Yeah.
But sometimes our knowledge of our body gets slightly skewed because of our chronic pain or chronic illness and the various things that go along with that. So it's building up confidence and looking at various factors that influence the journey and the current story.
Yeah. The importance of telling your own story is really true. Going back to that fear of being a burden, I think when you are experiencing a flare-up, or when you are experiencing, a period of high pain, you sort of feel like you don't have anyone to talk to, because if you're already relying on your spouse or a caregiver or something like that, you really don't want to burden them anymore. And I found that was so helpful when I finally found a physio, who in this case was a McKenzie practitioner. But I don't think maybe the modality was important, but it was really just because in whatever the 90-minute appointment I had, the vast majority of it, 3/4 of it, was just them talking to me and asking me questions. And just the process of saying things out loud and working out things, you realize that you do have a lot of the answers. And there's just something about it, saying it out loud that is very powerful. Regarding working with clients, I mean, and I know this is different for everybody, but what would success look like? So if somebody came in, and we could use any example, but if I could use back pain or something else if you think there's more relevant. What would success look like? So someone works with you, and you sort of provide them these tools, and they can kind of help you sort of co-create the solution by with the patient and the clinician working together. And then hopefully, what are we looking at in 6 months or a year? Can you kind of tell me what long-term living and strategies would look like?
Yeah, you're right. It is very much dependent on the individual, because two people with the same diagnosis will experience it completely differently for a variety of factors. I guess a success would be that the person has their own toolbox that they are comfortable in using. They know how to pace their activity so that they don't cause the flare up, but they're not overdoing things or underdoing things. We do talk about pacing activity a lot, which I can explain if that's helpful.
Please do.
Okay, so pacing your activity is basically when your nervous system is really super protective, which it often is in chronic pain. If you sit on your bum and do nothing, then you become deconditioned. That's part of that deconditioning cycle. And then your nervous system, when you try and do something, one, you're just not as strong or conditioned, but also your nervous system isn't used to you doing anything. So it has a bit of a meltdown. It tries to protect you even more. But if you push through and try and get everything done, particularly on it when you're having a better day, and then you find that you pay for it later on, it's usually because your nervous system has again had a bit of a meltdown and is trying to protect you because it thinks, oh my goodness, I should have stopped them sooner. I'm gonna limit them more next time. And it's finding that balance of not overdoing and not underdoing things, and it can be tricky because it can really vary. So we try and counsel people to find that level of activity they can do on a good or a bad day. But I am at the moment talking about people who with really sensitive nervous systems who go into flare ups doing, everyday activities. But the other, so I'm kind of off on a tangent now, but the other thing that we really see with chronic pain patients is life is a struggle. And they've lost sight of any joy, and it's just a struggle to continue existing. And often they might have other family members that they need to look after. Often the people that we work with are the ones that look after everyone else and forget to look after themselves. So I use that analogy of putting on your oxygen mask first so that you can then look after others. Because if you don't look after yourself, then there's no way you can look after anyone else, which is often the case that people are in that position, but they just don't have any sense. They've lost all sense of joy. And it's often about trying to find those chinks of light and what brings you joy. And it doesn't have to be, the things that bring us joy in life are generally not that big. It might be the bird song that you hear outside. It might be your cat or dog doing something daft. It could be anything really not that significant, but it's finding that, because when your whole focus is on your distress and your pain and what you can't do and that you're a burden and I should do this and I should do that, then it's like you're under this big cloud and there's no light coming in, and you need to find ways of chipping away so that you get little chinks of light, which really can help with pain and help with the distress. But it can be really hard when you're right in that tunnel or under that big cloud to see any light. And that was why I was thinking about Wild Strong and resilience, because it's so fun. I mean, it can be muddy and wet and wild, but that's part of the fun for me. But it's not necessarily going to be it's probably going to be very threatening for someone who's not in a big chronic pain shadow.
You need to get the dosage right, such as it is.
Yeah.
I mean, one of the things, that we really try to do with Wild Strong is when we were trying to decide what do we want it to be, we really tried to pull a lot from, the flourishing literature. So PERMA and various, positive psychology models. Because that's what we were thinking. It's not just the moving around. Moving is great, but it needs to be in the context of community, of a sense of reciprocity, having a nice time, feeling that sense of progress, feeling yourself grow and trying to create these sort of positive growth cycles. Because obviously, and we've already talked about a few, it's so easy to get into these limiting growth cycles, whether it's fear avoidance, whether it's pain avoidance, these deconditioning cycles that, seem to correlate um, with aging. And I don't just mean biological aging, but I think that when a lot of people, when they leave school or if they're lucky enough to go to university, they have this point in their life where they have access to physical activity and they have access to friends and support groups. And then I think that we see, for whatever reason, there's this sort of pull, there's this trajectory where as people get older, they have fewer and fewer friends, they have fewer opportunities to move, fewer opportunities to kind of just experience not even just joy, but just like maybe focus on the things that bring them contentment as well. And I think you're right. And I think this is really kind of where I want to take the conversation towards the end anyway, is, these are big structural and systemic factors. And I think one of the things that I think about over and over and over again is so much of the time when we talk about health, the onus is put on the individual,
Yeah.
but,
So true.
no person is an island. And this is a silly question, but I tried it the other day and it works. So if you could just sort of bear with me, I want you to imagine you've gone back in time and you are the equivalent of a billionaire. You're sort of, I don't know, Carnegie figure, but nice. And
Not Elon Musk then.
no, not Elon Musk. I don't think he's positive with his money recently or his power. But I want you to imagine it's 150 years ago, 200 years ago, whatever, and you have the ability to change society. You could change the infrastructure. You could change sort of the direction where everything has evolved. You can put your money and resources into things. How would you change the way things work so that, this feeling of pain or despair is somehow mitigated, because it is such a big systemic problem? What were some changes we could make? So if you had the resources, how would you fix it?
That is a really interesting question. I guess 200 years ago was the tail end of the Industrial Revolution, I think.
That's why I'm saying, I'm thinking tail end of Industrial Revolution. I thought that's a good place.
So, I mean, obviously the Industrial Revolution brought us a lot of really good, positive changes, but it seemed to have been, well, it wasn't the start, because there's always been greed, hasn't there? But those positive changes also led to a disconnection from the land and people moving into cities. And something that I've really noticed recently is that people just don't have the time to have proper conversations or interactions and take the care, even with customer service. And so I think I don't know how I would do it, but I would want to, whilst embracing the positives from the Industrial Revolution, also try to ensure that the environment was still really valued and protected, which obviously what didn't happen and hasn't happened and still isn't happening, and the importance of traditional ways as well as moving forwards. So I don't know how I would do it, but I think that's what I think is really important and that we've missed. And I think it's has manifested and is manifesting in various ways. And that's the increasing that greed of the super rich and the disparity between the people who are very wealthy and those that have not much at all. And that disparity is just getting bigger and bigger. And even, I mean, again, not to generalize, but a lot of the people that I see are struggling from a financial perspective. And that adds that whole other level of stress, which makes pain worse. And so being, and we have an NHS, which, is a brilliant thing, but it's struggling. So again, allowing, and this isn't anything I could change 200 years ago. I can't think what I would do, but having that ability to convalesce a bit for recovery, which we don't have anymore, because unless you're rich, because you've got to work.
I think of the word recreation, which I think we've sort of diluted a little bit. This idea of recreation, this point where you do need this time to regroup, to bring the stress levels down, to maybe think about your life. And you're right. I feel like there's so little free time now. I feel like all free time needs to be optimized by doing something.
Yeah.
And it's very hard for people to take time to help themselves. We're getting almost to the end of the hour, so I've got I got three more questions for you, but I think they'll be a little bit shorter. Okay. So if you had a friend or family member who all of a sudden was experiencing a flare up or acute pain, possibly back pain or something else, and you had to talk to them on the phone really quickly, and just say, it's going to be okay. You can get through this. What would you tell them? What tools or ideas or mantras would you give them to help them over the next few days or weeks?
So if it was acute back pain, they'd not had it before, I would obviously want, as a physio, I'd want to safeguard and make sure there was nothing else going on. I would probably give them some information about pain if they didn't know about it, why pain happens and this, and kind of help them understand over the phone is quite hard, but help them understand from what they've told me what's going on in their body and their nervous system which is why they're experiencing what they're experiencing. And I'd give them some resources to look at potentially, and suggest that they do some breathing work and keep moving little and often, but not to the point that they're causing themselves more pain. So it would be that just general, keep active. It is just pain. Just pain. I mean, it's all very well to say.
Yeah.
I have had neck pain for the last couple of days, and I haven't been able to sleep properly, and I've just been saying to myself, it's just pain. But it still hurts a lot,
Yeah, it still hurts.
So it's just pain. So I would be just thinking on what ways they could calm down their nervous system, and so that things don't spiral. And I'm often, as a physio, having friends ask me about stuff, and it's thinking, okay, well, if you've actually strained something, well, the healing process is 4 to 6 weeks in soft tissue, so it should be gradually getting better. It will get better, because if you panic, it sets off that whole cycle, and that panic about an acute pain can trigger a chronic pain response and can then trigger a lot of distress. So it's a bit of a waffly answer. I would be giving them some information and encouraging them to keep moving and with whether they can, but also they need to take medication in an acute situation. Then medication may be helpful, as well as the other factor, and also encourage them to see somebody locally if they needed to. But heat is often really helpful, or ice. It depends on if they've had this before. Then what helped you last time?
Yeah. No, that's good at building up that toolkit, like you said, both mental and physical. Well, that goes into my second to last question, which is, what resources would you recommend people check out? Are there any specific books or thinkers or any websites or anything you think are particularly helpful?
One I really like is called tamethebeast.org, and that's a 5-minute video by Lorimer Moseley. So he's one of the Australian pain scientists. He's physio in background. It's got great graphics, and it's a really good explanation about chronic pain. Other good resources, websites is Flippin Pain, so FLIPPIN pain. That's from the UK, as well as Pain Concern is another good one. There's some really good resources out there. I would say those would be there's loads, but those are two really good websites. And that video is great. It's got, as I said, it's got good graphics. You can probably get something else out of it each time you have a look at it, and it's quite useful.
All three of those are new to me, so that's great.
Really? Okay. Yeah.
So that's
it's
really
a really I like that video. Another. No, I'm going to leave it there on there. I can give you loads of resources. That's probably enough.
That's plenty. I'll definitely go check them out, and I can put them in the podcast notes as well.
Yeah.
Last question I often ask people is, what has you feeling optimistic? What are some trends that you've seen in the world? could be in pain or anything, but what are some positive movements you're seeing, something that has you feeling good about the future?
So in pain, there is definitely a move overall, certainly in the UK, to move away from injections that are not helpful and prescribing opiates, which is not helpful for chronic pain in general. Certainly high levels of opiates, and far more recognition of the impact of trauma, as well as something we haven't gone into today, an increasing understanding that people who are maybe not neurotypical have that has quite an interplay with chronic pain. So that's certainly giving me hope from a pain perspective. In the world in general, it's a bit of a tough week to be asking that, really.
It's a tough week. I'm sorry. Yeah.
I know some amazing people who are doing some really great work. I know my fellow Wild Strongers are all great. Yeah. We have movements like I don't know if you want to call it a movement, but things like Wild Strong are so powerful and really important. So things like that. I've got other friends who are doing amazing work. I've got a friend who's a clown doctor.
Wow.
Yeah. And so they go into, particularly work with children. They can go into hospitals or hospices, but also with elderly people, where they go and use humor and compassion and being present to help ease distress and bring some joy. So I've got lots of people I know are doing some really good things, and so I'm hopeful that might make a difference.
I think it's important to look at the local movements.
At the moment, it is,
the small
yes.
changes. Yeah, I think so. I think whenever things feel overwhelming, on the world stage, I think it's very important to see what are the positive things that are happening around you, and to try to make connections with those. Thank you so much for your time. There's a lot more we could have talked about. I mean, I really would like to, maybe if you have time in the future, talk to you a bit about trauma and, like you were saying, neurotypical experiences of pain. We also didn't get to talk about, gendered experience of pain, which I think would be
middle-aged women.
Yeah, middle-aged women.
I can talk about that because I am one.
Yeah, and I think women in general, but middle-aged women.
Yeah.
So, I mean, when you have the capacity in the future, maybe in 6 months or so, I'd love to get you back on and talk about some more things. But thanks so much for your time. I really appreciate it. This is really helpful, and I really got a lot out of it.
Great. Thank you, Andrew. I really enjoyed it. It's made me reflect on things that I don't probably normally reflect on. But there is a lot of great stuff out there, and I think what you guys are doing is really positive. So thanks for having me.
Thank you.
It's a daily exercise. It's a daily exercise. It's a daily exercise.
Oh, thank you very much, Joanna. And thank you, listener. What I like to do is when I'm editing these, is to take the podcast to a little walk and I listen to it. And tonight, it's very, very dark, but it's really beautiful stars. And it was just a very nice podcast to listen to, because it made me realise, first of all, I've never really had chronic pain. So I think perhaps I mean, obviously I don't understand it, but it made me really think about my friends that have suffered from it, and actually one in particular who suffers with chronic pain, and how little I really understand. And this has really made me think about that. So I think I'll give her a call after this. But it also made me think about when Andrew had his back injury, and it's good to think about how other people are feeling, and generally I'm quite empathetic, but I found that very helpful, and I hope you did. Please do share it as well if you know somebody that's suffering from pain. Do share the episode, that would be lovely. And just, I guess the takeaway for me is to remember that the road to recovery is rarely linear, and resilience isn't built overnight. It's just about taking small steps, and having the help of a community, whoever your community is. So thanks so much, Joanna, for coming on and talking to us. Next week, we are darting over to the world of natural movement. So we're excited to bring you Rafe Kelly from Evolve Move Play. A lot of you, I imagine, will know Rafe's work. He has been playing around with natural movement for much longer than Wild Strong has been around, but has had a really big impact on our thinking, particularly Andrew. I think he remembers listening to a podcast of Rafe Kelly's about, I don't know, I'm going to pluck a number out. I'm going to say about 11 years ago, because we still lived in Southeast Asia. So yeah, it was then. And yeah, it'll be really interesting. Rafe comes from a parkour background and teaches kind of playful natural movement, often outside, has a lot of really good things to say about it, and has been in this field for a really long time. So yeah, has seen all the trends come through, and he's still there producing some excellent content. So look forward to that, and we will see you next week. I need to stop walking around in the dark without a head torch. Have a lovely week. See you soon.